Hi, my name is Abby Stevens. I'm a statistics PhD student at the University of Chicago, and today I'll be talking about some work I've done on modeling the impact of social determinants of health on COVID-19 transmission and mortality in order to better understand health inequities. Since early in the pandemic, we've seen many reports of COVID disproportionately impacting people of color in the United States. The latest stats show that Black people are dying at over 1.5 times the rate of white people, with Native Americans and Latinos dying at a significantly higher rate as well. Economic hardships, which have of course impacted most of the country, have been worse for non-white Americans. Prisons and jails, whose populations we know to reflect the structural racism encoded in our criminal justice system, have routinely shown up as COVID hotspots. For example, in Chicago, the Cook County Jail, which is one of the largest jails in the country, was a major hotspot in the spring and is even worse now. Public health experts have hypothesized that these disparities can be largely explained by what are known as social determinants of health, which are the economic and social conditions that influence individual and group differences in health status. Social determinants of health, or SDOH, include things like access to quality medical care, education, economic and workplace conditions, housing, and social and community context. Disparities related to these factors that might impact COVID outcomes include underlying chronic health conditions, lack of insurance and access to quality medical care, substandard housing, and jobs that limit the ability to practice social distancing, and incarceration. In this work, we seek to formalize and test hypotheses around how social determinants of health impact COVID transmission and mortality. First, we'd like to better understand and quantify the factors that explain the observed racial disparities. We're specifically interested in how occupational risk impacts transmission. For example, while most of us working in data science were able to effortlessly transition to working from home back in March, much of the workforce was not, limiting the ability of those workers to social distance and protect themselves. We're also interested in how housing factors such as housing density and those experiencing homelessness have played a role in the transmission of COVID, and how this relates to the geographic variabilities we've seen in COVID transmission. And finally, we'd like to better understand the extent to which comorbid health conditions such as diabetes and heart disease contribute to disparities in the COVID death rate. We believe that better understanding the source of the observed disparities in COVID outcomes will help inform our mitigation strategies, such as targeted interventions and vaccine prioritization. In order to test these hypotheses, we leveraged CityCovid, which is a large-scale agent-based model of the spread of COVID-19 in Greater Chicago. CityCovid is a project I've been working on since April with Argonne National Lab. It models the entire population of Chicago synthetically, which is statistically representative of the actual Chicago population based on census and other survey data. Our model studies where people come from and where they go, and how this results in people being co-located and providing transmission vectors for COVID-19. It then studies the effects of these activities and co-locations on the infection peak. We also model different intervention strategies and study the effects of these interventions, such as restaurant closings and mask wearing, on the curve. We work closely with the Chicago Department of Public Health, the mayor's office, and the governor's task force to provide various what-if scenarios to decision makers. CityCovid is based on an agent-based model known as CHISIM that has been used to model MRSA and Ebola previously. This model is highly granular and is enabled by a decade's worth of experience at Argonne and UChicago in using ABMs to model infectious disease transmission. For a given simulated day, our synthetic agents, who have been generated to have attributes that reflect the statistics of the population we're modeling, move hourly from place to place within our synthetic ecosystem based on a schedule we've assigned to them. Shown here is an example of a simulated week with bar height representing the density of people at a given place type at each hour for regions across the Chicago area. Sitting on top of our simulation is a compartmental epidemiologic model such that when people are located at the same place at the same time, there's a probability of transmission based on infection status and individual attributes. Agent-based modeling is one of the best methods we have to model complex, dynamic, interacting systems. We have the ability to model micro-level behavior and interactions and study their macro-level effect. This enables us to recreate emergent nonlinear phenomena in complex systems and endogenously model contagion networks of COVID. Underlying city COVID is a realistic and dynamic synthetic population. A large part of the heavy lifting on this project has been to build a synthetic population that is granular enough to test our hypotheses. We started with an already built synthetic population developed by a group called RTI. This population reflects statistics from the 2018 ACS estimates down to a census block group level and includes basic demographic, household, and school or workplace information. Now, to actually use this population in our model, we need to assign activity schedules to each person so that the model knows where to send them at each hour of the day. To do this, we've mapped schedules from the American Time Use Survey and the Panel Survey of Income Dynamics to people based on age, sex, and race. These schedules tell us where and what a person is doing throughout the day for an average weekday or weekend. The model can then send agents to the appropriate place at the appropriate time based on their schedules. Next, we've significantly expanded the list of available place types to send our agents to using data from SafeGraph. SafeGraph is a company that uses anonymized cell phone data to track traffic to major points of interest across the United States. For each point of interest, we know the distribution of visitors by day, hour, and even by origin census block group, which enables us to pretty accurately map these places onto our existing persons and activity schedules. This ensures that our model follows realistic mobility patterns that maps directly onto the actual city that we're modeling. The final major addition to the synthetic population that we made was to assign ethnicity to our agents using ACS data, as well as chronic health conditions, specifically diabetes, asthma, hypertension, and obesity, using data from the Chicago Department of Public Health. So here's the development workflow for our synthetic population. As we can see, there are a lot of moving parts, and it's extremely important that throughout the process of joining all these data sets together, we maintain statistical accuracy across a number of axes. This ensures that the population we are feeding to our agent-based model reflects the true population to the best of our ability. One example of this is assigning underlying health conditions to our population. As you can see here, there is significant heterogeneity among different subgroups of the population. Here we're showing the incidence of diabetes by community area in Chicago, by age, and by race ethnicity. There are also strong correlations between the underlying health conditions themselves, like diabetes and obesity. And so when we assign them to persons, they cannot be independent from one another. This posed a statistical challenge for us that we were ultimately able to resolve using an MCMC-based approach. So now that we've developed a synthetic population that is granular enough to capture the complex dynamics of COVID transmission and mortality, we are able to test the hypotheses around disparities in COVID outcomes. One way to do this is through a full deployment and parameterization of city COVID, which is updated to allow state transitions to vary according to agent attributes. So the first place where disparities might show up in our model is in the exposure stage. And these will show up through activity schedules and place assignments. As we discussed before, workers who can easily work from home have been at a much lower risk throughout the pandemic than essential workers who have been required to be at their workplace throughout the pandemic. There are other factors like household structure that may also impact the amount of exposure an individual has in city COVID. After exposure, an agent either becomes asymptomatic or symptomatic, and if they're symptomatic, they may become hospitalized. The probability of each of these events occurring is based on comorbidities and age. And finally, if an agent becomes hospitalized, the severity of their illness is based on, of course, agent comorbidities, but also on race and hospital quality. So these disparities are all built into the transition probabilities of city COVID, and we are able to tweak and tune parameters to understand the extent to which the different sources of disparities impact overall rates of COVID hospitalizations and mortalities. Running city COVID requires the use of a supercomputer, and this experimental framework is still being developed at Argonne. However, what does not require a supercomputer, and what I can do on my own computer, is the generation of contact or co-location matrices. Now, because of the granularity of our synthetic population, we are able to create very specific contact matrices that help us answer our hypotheses. One of our key hypotheses for this project is around the transmission of COVID at the workplace and to better understand how disparities show up there. As an example, here we've enumerated contacts between workers and visitors at restaurants, separated by income, race, ethnicity, and age. We see some interesting patterns here. For example, there are far more restaurant workers in lower income brackets than there are restaurant visitors, and there are more Black workers interacting with white visitors than the other way around. These matrices provide a useful way to, at a high level, understand the patterns of interactions taking place in city COVID without running the entire simulation. This is ongoing work, and the first next step is to fully operationalize our hypothesis testing within the city COVID agent-based model. This requires updating the epidemiologic model that sits on top of city COVID, as well as updating some of the internal mechanics of the model to allow for logging at a higher granularity to better track where disparities are showing up in transmission, in hospitalizations, and also in mortality. Part of this is to incorporate place-specific transmission risks, which will be based on things such as the size of the place, the density of the number of visitors and workers at that place, and also the activity types that can take place at a given place. Next, we'd like to allow our synthetic population to dynamically update. What we mean by this is that as behaviors change based on policy and other factors, we'd like that to be reflected in our population for the most accurate modeling possible. And finally, we'd like to update our model to include vaccine rollouts, as that will have a large effect in how the pandemic is going to play out moving forward. Thank you so much for listening to my talk. I'm Abby, and I'd like to say a huge thank you to Argonne for involving me in this work, and also to the organizers of this event.